So much for the invite. I'm really grateful to spend some time with you this evening and share with you a little bit about what I've
Recording in
learned in terms
progress.
of cardiac arrest in the operating room. So let me just work through some technological stuff and share my screen, make sure that we are all on the same page. Okay, you should all be able to see my screen at this point. So, as I said before, I'm really excited to spend some time with you. And the title of my talk this evening is The Invisibles. This is going to be about how anesthesiologists prevent cardiac arrest. Here are a few disclosures. I'm on the board of directors of the American Board of Anesthesiology. I serve on the advisory board for two companies, Phys Medical and TelHealth. I'm an editor for Up to Date, and I sit on the Pearls editorial board for the American Society of Anesthesiologists. And this evening, I'm excited to ask you all a simple question. What do you think a fact checker who catches a publication error, a graphic designer who designs a book without a byline, and a piano tuner who prepares a piano before the concert have in common with an anesthesiologist? All of these jobs are characterized by the three traits of meticulousness, great responsibility, and internal award. Simply put, as a specialty, we are the antithesis of social media influencers and attention cravers. In 2012, this author, David Zweig, authored a piece in The Atlantic and argued that anesthesiologists and fact checkers share a profession. Both of us are what he called the invisibles, people whose work is defined by being unseen. When we do our job perfectly, nobody may notice. Nobody may thank the fact checker for the error that never made it to print. Nobody thanks us for the arrest that never happened. And it's the reason this talk matters, because our success makes us invisible. So today I want to talk about how we keep being invisible through the lens of Pearl's guidance. Pearls stands for Perioperative Resuscitation and Life Support and offers a series of algorithms and recommendations using grade methodology to guide the work that you and I do. After all, none of us want to be experts because of our ACLS experience. We want to prevent cardiac arrests. I'm curious for those of you in the audience, how many of you would agree with this statement? I would benefit from more training in the management of intraoperative cardiac arrest. According to this survey, 70% of anesthesiologists agreed with that statement that they would benefit from more training. And that's why I'm excited to learn with all of you tonight. I am a big fan of the history of medicine. And believe it or not, anesthesia is front and center in the origins of CPR. I want to take you back to the 19th century when Friedrich Mass, quoted here, reported the first successful closed chest cardiac massage in a person. And he said that I now had to regard the patient as dead. In spite of this, I immediately returned to the direct compression of the region of the heart. Now, what you may not know is that his discovery was the result of his efforts to manage something called chloroform syncope, a condition described at that time as an irreversible state with sudden circulatory collapse. Let's fast forward about 40 years to 1935, when anesthesiologists working in Philadelphia created the Anesthesia Mortality Committee to review and discuss the mortalities related to anesthesia, with the specific goal of choosing cases where an error was suspected. In 1947, they published their findings confirming that deaths in the operating room do not resemble deaths in the field or on the street. They reported 307 errors that included excessive doses of agents, respiratory obstruction during an operation, and errors in technique. At that time, almost 90% of inefficient resuscitations were thought to be preventable. And when you look at this list from 1947, it doesn't quite resemble the familiar H's and T's that we may have learned from the American Heart Association. Because our world is different. I want you to listen to this description of the work that we do. The pattern of injury was similar in that the patient was sedated in a dark room with intense intermittent procedural stimulation, with the patient breathing spontaneously, monitored only by a pulse oximeter until desaturation, bradycardia, and apnea developed, resulting in cardiopulmonary arrest and anoxic brain damage or death. In 2012, a small group of us published a set of algorithms in the Canadian Journal of Anesthesia. We called it Anesthesia Advanced Circulatory Life Support. It was, at its heart, an argument. We argued that arrest in the operating room deserved its own framework, but we had very little to anchor the argument with. Most of what we wrote was opinion and the accumulated wisdom or experience of people who had been watching arrests for decades. The argument that we were making is that arrests in the OR are different than arrests in the field for several reasons. Because the arrest is witnessed, the cause of the arrest is often known, and the rescuer is known. We are not saying, Annie, Annie, are you okay, as we may have been instructed by the AHA. 6 years after that first paper, a two-part update was published in Anesthesia and Analgesia by 12 experts. But if I'm honest with you this evening, we were still anchoring from expertise more than from evidence. And there was this inconvenient truth underneath all of it. Through these three papers, two sets of American Heart Association revisions, no drug had been shown to improve long-term outcomes in cardiac arrest. Not epinephrine, not vasopressin, not amiodarone. The randomized trials we needed cannot be ethically run. So when the next iteration of our paper came around, the question was no longer what algorithm to draw, it was what to do with the evidence that we already had. In other words, what would it take to stop writing from expertise and start writing from evidence? The answer was GRADE. And in 2025, what we now call PEARLS, Perioperative Resuscitation and Life Support, was published in Anesthesiology. We worked in conjunction with the Cochrane Group and used GRADE methodology to ask 12 questions and provide 13 recommendations. My goal today is to highlight some of the answers to those questions today. How do we begin to apply this science to the work that we do? Let's pause for a moment and ask ourselves whether or not we are comparing apples to oranges in this application, because most of us are not resuscitating patients in the field. Our patients are in the operating room. Our patients can arrest from anesthetic situations such as local anesthetic toxicity or drug administration error or respiratory complications such as autopeep and cardiovascular crises such as increased intra-abdominal pressure or transfusion reactions. So let me test this assumption and try to make this somewhat interactive and ask you to reflect on how we think about cardiac arrests. What do you think is the most common cause of arrest in the operating room? Take a moment, take a guess, and hold that guess in your mind. Hemorrhage is the most common cause of cardiac arrest, accounting for 17% of arrests in the perioperative setting. Before you think about a patient's rhythm, you are thinking about where the blood is actually going. And I want to bring your attention to this audit of cardiac arrests from the United Kingdom. This audit reviewed 881 cases of perioperative cardiac arrest and found an incidence of 3 in 10,000 cases. Cardiac arrest in the OR is not a zebra. It's not rare. It's common enough that most of you in this room have seen one or will see one. And what we've also learned is that the type of surgery matters. So, what's the most common cause of perioperative cardiac arrest in patients who have abdominal surgery? The answer here is sepsis. What's the most common cause of perioperative cardiac arrest in patients who have cardiac surgery? The answer is ischemia. What is the most common cause of perioperative cardiac arrest in patients who have ENT surgery or ear, nose, and throat surgery? The answer is hypoxemia. What's the most common cause of perioperative cardiac arrest in patients who have vascular surgery? The answer again is hemorrhage. What's the most common cause of perioperative cardiac arrest in patients who have gynecologic or urologic surgery? The answer here is a bradyarrhythmia. Remember, our success makes us invisible. And part of that success includes preventing the arrest from actually happening. After all, do we want to have an accumulated wealth of experience in managing arrests or preventing them? As clinicians, we often witness clinical scenarios deteriorate in front of our own eyes, and having the opportunity to intervene during the pre-arrest phase is an opportunity for us. Here are three tables from the Pearls manuscript, which outline management for pulmonary embolism, anaphylaxis, and high spinal. In all of these tables, there is a focus on what can be done before a cardiac arrest. For example, with a pulmonary embolism, in the pre-arrest phase, we would want clinicians to stop gas inflation if there was a suspicion of a carbon dioxide embolism, flood the surgical field, administer 100% oxygen, place the patient in Trendelenburg position. For a cardiac arrest, we would want our clinicians to discontinue a cardiac arrest in neuroaxial anesthesia. We would want our clinicians to discontinue the anesthetic, intubate for respiratory distress, treat the bradycardia with IV atropine or IV epinephrine. Two of the most important algorithms in the Pearls paper are designed to prevent a cardiac arrest and outline the difference between management of left ventricular and right ventricular shock. The focus for left ventricular shock is afterload reduction, and the focus for right ventricular shock is ensuring that there's a high enough pressure to ensure right coronary perfusion. Fluid management is ubiquitous in our practice. We suggest using pulse pressure variation from the arterial line to guide fluid resuscitation. Why? Because without a measure of fluid responsiveness, a blind bolus increasing cardiac output, it will only occur in about half of patients. In the other half, you're giving fluids to someone who does not need it. And in the perioperative patient, excessive fluids is not benign. During episodes of crisis, our adrenaline can be high. And intuitively, we may be handbagging the patient with the best of intentions. But I want you to remember that we should not choke the circulation. I think it's important to remember that the heart does not live in isolation. Simply put, the heart and its very own personal Frank Starling curve live inside the thoracic cavity, surrounded by what I like to call the pulmonary sponge. And this sponge, with inflation, with inspiration, can choke the circulation. Hyperventilation is deleterious. It is bad in all conditions of a low flow state. The duration of increased intrathoracic pressure is proportional to the tidal volume, the inspiratory time, and the ventilation rate. Ventilation is inversely proportional to coronary and cerebral artery perfusion. In other words, we need to resist the urge to aggressively ambu bag our patient. Published data shows that aggressive ventilation in a variety of disease states such as hemorrhage, ARDS, and cardiopulmonary resuscitation can worsen already low flow states. If this waveform is seen in the operating room, where there is a failure for the expiratory flow waveform, the waveform here that's in yellow, to return to baseline, we should change our ventilation strategy, especially in low flow states. Now is not the time to hyperventilate the patient to correct hypercarbia. For ventilation during CPR, we aim for 10 to 12 breaths per minute. The reason is mechanical. Hyperventilation traps air, the expiratory flow waveform on your monitor. The thing we never look at does not return to baseline if we hyperventilate. That causes autopeep, and autopeep kills venous return. You are squeezing harder and getting less. We need to slow the ventilator down. The H's and T's are often used to help establish a diagnosis, particularly with bradycardia and PEA arrests. The American Heart Association has traditionally focused on 5 H's and 5 T's to recognize reversible causes of cardiac arrest. In fact, in the most recent AHA update last year, these 5 H's and 5 T's still remain. In 2012, when we began our Pearls journey, we proposed that perioperative arrests are different and generated this table outlining 8 H's and 8 T's specific for our patient population. In addition to the classic 5 H's and 5 T's, we included hypoglycemia, malignant hyperthermia, and hypervagal causes for the H's, and trauma, QT prolongation, and pulmonary hypertension for the T's. In our most recent update last year, we've expanded our H's and T's to 9 H's and 9 T's to now include hypocalcemia and intra-abdominal hypertension. We also recognize that stopping at the H's and T's is not enough. It's important that we make a diagnosis. This table found in Pearl's guidance provides potential causes for each H and T. For example, for hyperkalemia, we should consider acute kidney injury, transfusions, reperfusion injury, and diuretics for hypokalemia. For intra-abdominal hypertension, we should consider peritoneal insufflation, ascites, abdominal bleeding, and abdominal packing. Remember, our success makes us invisible, and part of that success includes making a diagnosis. Early in our comprehensive algorithm, we ask clinicians to consider diagnosis and ask whether or not the cause of cardiac arrest is a hypervagal or hypovolemic scenario, an embolism, local anesthetic toxicity, hyperkalemia, or hyperventilation. You will find similar prompts in the Pearls algorithms for bradycardia and tachycardia. In the latest iteration of the comprehensive algorithm, we also include a new mental model to consider in the context of a PEA arrest. The evaluation of PEA can be simplified by categorizing the QRS complex as either narrow or wide. This tool here suggests that narrow QRS complexes are often caused by a mechanical problem, such as tamponade, a pneumothorax, a pulmonary embolism, or mechanical hyperinflation, and should initially be treated with fluids. A wide complex may signify a metabolic crisis, such as hyperkalemia or local anesthetic toxicity or pump failure, and will often require pharmacologic interventions. Let's imagine for a moment that we're taking care of a healthy 31-year-old soccer player who presents for a knee arthroscopy. He receives a spinal injection of isobaric bupivacaine, and his vital signs after injection are notable for a heart rate of 55 and a blood pressure of 95/55. A propofol infusion is started, and he undergoes a knee arthroscopy that lasts for 35 minutes. He goes to the PACU or recovery room, where he experiences some nausea and then has a cardiac arrest. I hope this slide challenges how we may think about cardiac arrest after neuroaxial blockade. The idea that spinal arrest occurs only with high spinals is false. The concept that spinal arrest occurs only with respiratory depression is not true. And the idea that spinal arrest always occurs shortly after injection is also false. This study was published a little over 30 years ago, and investigated the hemodynamic effects of epidural anesthesia in 8 healthy volunteers. In 2 patients, there was a dramatic decrease in heart rate and blood pressure after injection of epidural anesthesia. These changes were observed 25 minutes after injection. Note that sympathetic blockade of the heart was an unlikely explanation because of a T8 and T10 level. Central volume depletion activates vagal stimulation, causing bradycardia. The administration of saline resulted in an increase in the patient's heart rate. Several theories have been proposed to explain why spinal arrests occur, including unrecognized respiratory depression, excessive sedation with a high block, ventilation, and autonomic imbalance. During the perioperative period, cardiac arrest in association with neuroaxial anesthesia is difficult to predict and may occur more than 40 minutes after injection. In a review of neuroaxial cardiac arrests, almost 50% of cardiac arrests were associated with recurrent specific surgical events, cementing of a joint, spermatic cord manipulation, manipulation of a broken femur, blood loss, and rupture of amniotic membranes. Unlike so many scenarios in medicine where sick patients are at risk for poor outcomes, spinal arrest is a circumstance where the risk is with healthy patients who may have high vagal tone. Risk factors include age less than 50, a heart rate less than 60, ASA 1 or 2 status, and a sensory level above T6. Our best evidence for this topic remains case reports, and this is a case series of 5 patients I want to highlight. In this case series, none of these patients had respiratory depression. The time interval for bradycardia or asystole was 10 to 70 minutes after injection. The neuroaxial level varied between T3 and T8. CPR was performed in the 4 patients with asystole. All patients received more than one type of medication, and all patients survived to discharge. I think it's helpful to divide the management of hemodynamic collapse with the spinal into 2 phases, the pre-arrest phase and the arrest phase. In the pre-arrest phase, we would do interventions like give atropine for bradycardia or epinephrine. We might consider transcutaneous or transvenous pacing. In the arrest phase, we would start CPR, administer 1 milligram of atropine or 1 milligram of epinephrine if there's no response. In the PEARLS guidance, there are specific recommendations on how to escalate, with the suggestion to administer 1 milligram of atropine or 100 to 200 micrograms of epinephrine. I also want to highlight that if there's no response, the table suggests administering 1 milligram of epinephrine. Local anesthetic systemic toxicity, or LAST, occurs in roughly 1 to 10 events per 10,000 cases, except for peripheral nerve blocks, where the rate is closer to 1.8 per thousand and almost certainly underreported. In 2006, the first case report appeared in the literature. A patient in cardiac arrest from bupivacaine toxicity during regional anesthesia was treated with intravenous lipid emulsion. The patient survived, and for a decade after that, our evidence base was 1 case report, then 2, then a series, and eventually several hundred in patients of every age and every context, with a reported survival of approximately 85 to 95%. PEARLS recommends an infusion of 20% lipid emulsion in perioperative patients with LAST. And the dose of epinephrine in LAST is different, smaller than you would use in other arrests, 10 micrograms for hypotension, 100 to 300 micrograms for an arrest. Standard doses can be harmful here. Animal studies suggest that the metabolic effects of epinephrine on the already poisoned myocardium works against you. So let's switch gears for a moment and talk about epinephrine. This is a story that begins more than 120 years ago in 1901. At that time, a Japanese chemist working in Parke Davis Laboratories in Detroit crystallized the very first pure hormone ever isolated from a living gland. He called it adrenaline. Within a year, surgeons were using it to stop bleeding, ophthalmologists were using it to whiten the eye, and physicians were injecting it directly into the heart. One molecule with an entire pharmacopoeia, and we've been arguing about it ever since. Remember this slide. No drug, including epinephrine, has been shown to improve long-term outcomes in cardiac arrest. In fact, with the inconvenient truth underneath all of it, we don't know what the best dose of epinephrine actually is. Many previous publications listed here show that epinephrine may improve return of spontaneous circulation, but it is associated with equivalent or even long or adverse long-term outcomes. In several of these studies shown here, epinephrine outperforms control groups and placebo initially, but eventually outcomes with epinephrine begin to deteriorate. One thing is clear, that in the house of medicine, anesthesiologists know how to titrate medications better than anyone else. We are not a one-size-fits-all specialty, and in our hands, epinephrine dosing can make us invisible. In the comprehensive algorithm, we begin with a suggested dose of 100 to 300 micrograms, which may be repeated with a second dose of 100 micrograms to 1 milligram. Note that we did not feel that we are bounded by a clock to dose epinephrine every few minutes, but rather to titrate by end-tidal CO2 and diastolic blood pressure. Again, in the bradycardia algorithm, Pearls highlights 10 to 100 microgram doses as an initial bolus. And we're not alone in our view of epinephrine. Here's an algorithm for cardiac arrest management in cardiac surgery patients, where the instructions are actually do not give epinephrine unless a senior doctor advises this. For the initial management of anaphylaxis, Pearls recommends administering 50 micrograms to 100 micrograms intravenously of epinephrine and to escalate to 100 to 300 micrograms if hypotension persists. In the setting of an arrest, the table for anaphylaxis management provides a range for epinephrine dosing from 100 to 1,000 micrograms. For malignant hyperthermia, we strongly recommend dantrolene, 2.5 milligrams per kilogram intravenously. And I want to highlight what GRADE says next to this recommendation. This recommendation has moderate certainty of evidence. In fact, moderate is the highest certainty of any recommendation in the 2025 paper. And this is a drug for which there has never been a randomized controlled trial, because there never will be one. The evidence is observational. What makes it moderate is that the signal is overwhelming. A Japanese series of 338 cases showed a 27% absolute decrease in mortality with dantrolene. The directionality is consistent among papers, the mechanism is understood, and so GRADE elevates the degree of certainty. I want to end this clinical section with a recommendation that's new for this paper for traumatic cardiac arrest. Before definitive bleeding control, this means a mean arterial pressure of 50 or a systolic pressure of 70 in hemorrhagic shock. Aggressive pressure management can push the clot off, dilute coagulation factors, and can worsen the bleed. You may buy 30 minutes of blood pressure, but you may also lose the patient. There have been 9 randomized trials and 17 observational studies suggesting that permissive hypotension may reduce mortality. The certainty is very low, but the direction is clear. And one more, for a patient who arrests in the prone position, let's imagine a posterior spine case. The 2025 paper suggests that we start compressions in the prone position rather than turning the patient supine. There's no randomized trial here. There are observational reports. The mechanics work. The time you lose flipping a patient is the time the patient may not have. Here in figure A, the hands are placed in the inferior angle of the scapula at the estimated T7 to T9 vertebral segment level. Figure B demonstrates a similar method that allows for sparing of a potential midline incision. Throughout this talk, we've discussed hypoventilation, ventilation, hypotension, diagnosis, perioperative physiology, and cardiac arrest. But remember, the goal is not to become an expert at resuscitation. The goal is to prevent the need for a resuscitation. The invisible anesthesiologist is not the person who performs CPR. The invisible anesthesiologist is the person who recognizes the diagnosis before CPR is needed. Nobody will congratulate the clinician who prevented the first domino from falling, but that is often where our most important work occurs. Remember David Zweig, the author of The Invisibles. He described the invisibles as people whose work is defined by being unseen. The fact checker, the piano tuner, the graphic designer, the anesthesiologist. The purpose of pearls is not to make us visible. The purpose of pearls is to make our work visible so that we can continue doing what anesthesiologists have always done, making a diagnosis, preventing arrests, and remaining invisible. And on that note, thank you very much and happy to take questions.
Okay, okay. Thank you. That's it. Well, thank you very much for that incredible lecture and that great conclusion that actually we do need to become invincible. Well, invisible, maybe maybe also invincible. Both, both would work. So, there's not a question right now for you, but I will start asking something, and let's hope they decide to make a question. The first question that I have is in your setting or in the places that you have adapted pearls, how do you train your teams so they can apply it and become invisible?
I'm muted.
Never mind. Yeah.
This is where I think simulation has just such a profound effect on training to get people to understand it. So we use our simulation center to to teach many of these concepts in pearls. And it's interesting because we weren't really sure, you know, has practice changed very much? And so we just did an internal retrospective study looking at our epinephrine dosing in 70 cardiac arrests over the last 5 to 7 years. And it's interesting because over 50% of the time, our initial epinephrine dose is less than 1 milligram, which is very aligned to the practice of what we've been teaching. It's interesting. And, we're going to try to publish it. And if it gets through peer review, like the punchline is there's no difference in return of spontaneous circulation. And that many of these patients get doses less than 500 micrograms and survive.
Okay. Actually, related to this comment, well, it is about adrenaline and says Vanessa is asking what is the lowest dose that you have ever used in cardiac arrest?
100 micrograms for an actual arrest. I think if someone is sort of in that pre-arrest phase, I'll use 10 micrograms. Like I might use that if I'm starting to suspect someone's developing bronchospasm, for example. I might say, here, let's just give 10 and see what happens, and then quickly escalate to 100 if that doesn't work. And then even after 100, I might go to 500 before giving the first milligram because often there are times where in these arrests, let's say the arrest is from insufflation of the abdomen, where you just need to give a baby dose of epinephrine, desufflate the abdomen, and the patient regains their pulse very rapidly. And there's harm, I think, in that scenario if you give a milligram of epinephrine where they now might develop an arrhythmia that you're going to have to be dealing with that is a pure consequence of the drug and not the actual arrest.
Yeah, actually, in the last webinar we had, the speaker was sharing with us this story that it is being, well, it's ongoing, and they are reviewing if those high doses of adrenaline in pediatrics are the ones that are causing several cerebral damage or vascular
Yeah.
events after cardiac arrest, even in hypoxic cardiac arrest that were resolved very fast. So might relate. Well, we have a question from Emiro from Colombia. Thank you very much, Dr. Moitra. I don't know if you can see it. If is there any intraoperative transesophageal echocardiography parameter that can be used to guide cardiopulmonary resuscitation? He put the example using BTI.
Yeah, great question. I'm just thinking now, it was probably mentioned this is the first time I've given this talk after Pearls, and I'm thinking that your point is one I should add to the next iteration of this talk. And I think the most unique perspective to think about is a transesophageal echo can guide your hand placement. And in many, many cases, chest compressions are occurring over the left ventricular outflow tract. And we can guide patients to move their hands to place them over the left ventricle, in which your actual cardiac output will be much better. And I think this is a very thought-provoking scenario to think about in the context of how we interpret end-tidal CO2 values when someone's arresting, because hand position may literally be affecting that, and may falsely give you a sense of even return of spontaneous circulation if all of a sudden you have a rapid increase in end-tidal CO2 by moving your hand from the left ventricular outflow tract to the left ventricle. I don't think VTI would be useful during a cardiac arrest. I would just assume the VTI is terrible.
Yeah, actually, there's these videos on which they are compressing and they are like over the aortic valve, and so they're closing and causing spontaneous contrast. Well, there's was a question, previous one. Well, they are asking about spinal arrest, or I suppose cardiac arrest associated to spinal anesthesia. But they first ask why it's atropine the first drug to use. What about if the patient has low blood pressure? Should I go epinephrine or norepinephrine?
That's a really great question. Atropine was originally in the AHA algorithms, and one of the reasons it was taken out is not because it was ineffective, but because the algorithms were trying to be simplified for, the paramedics and EMTs and sort of first responders. Atropine has been a part of the arsenal of anesthesiologists for many, many years. And so when we did our Pearls manuscript, we asked a very specific question, whether or not atropine has been used successfully for spinal arrest. And the answer is yes. To be fair, epinephrine also has a series of cases in which epinephrine has been used to manage a spinal arrest. I don't have very strong feelings about which one you use first. What I do have strong feelings about, though, is that if you don't escalate your therapy, that is the reason you get into trouble in this scenario. And there has been a paper that was looking at lawsuits associated with cardiac arrest and spinal arrest. And the reason many of these lawsuits were happening is that the clinician didn't escalate. So they would give ephedrine, the ephedrine wouldn't work. They would, for some reason, give phenylephrine, that didn't work. And they never went to the next level. I also think norepinephrine, just to get to your question, is very reasonable. There is no wrong answer here with atropine, epinephrine, and norepinephrine. And that, again, is, I think, what makes us different than someone who might be on the street doing this resuscitation. You are experts with these three drugs. You know how your patient is responding. You will titrate and figure it out. I trust you to be able to make that decision. So all three are options. And in fact, I didn't show our recommendation for norepinephrine, but it's actually in the Pearls paper to use it.
My next question is a personal one related to norepinephrine and non-shockable rhythms. I suppose it goes in that direction, maybe.
Yeah, I mean, I think non-shockable rhythms are really where the diagnosis part makes the biggest impact because non-shockable rhythms often have, early on at least, a reversible cause. And so I think norepinephrine can certainly buy you time. I think epinephrine can also buy you time, but it's buying you time to
Okay.
come up with a diagnosis. What will not work in a PEA asystole scenario is giving norepinephrine and epinephrine and not doing anything else but CPR. That never works. You must do something. It's often placing a breathing tube. But if it's not placing a breathing tube, you need to find that other cause.
Yeah. Well, um, I just got a great idea that I wanted to share, but there are a lot of questions, so I'm going to focus on the questions. David Ayala asked if it's reasonable to leave an adrenaline infusion during cardiac arrest. Have you thought about it, or maybe the same question?
Yeah, it's certainly not wrong. I think the question is, are you giving an adequate enough epinephrine dose that you can titrate to the scenario that is in front of you? And also the time it takes to set up the epinephrine infusion if you don't have that ready. I wouldn't want to be distracted from effective chest compressions, the cognitive load of coming up with a diagnosis and making sure that you're going through your algorithms to set up the infusion. But it's certainly not wrong. And if it's available, having a background infusion would be reasonable. I think anaphylaxis comes to mind as one that would be like particularly helpful, where you're giving your doses of epinephrine as boluses, because sometimes those patients just require a lot of epinephrine and you have an infusion in the background.
Okay. There are some other questions, but they all relate to this one, and think you have solved them. There's a new one, head up CPR. Do you think it has an space in operating room?
Yeah, we didn't. I don't. I don't think we have the evidence to support that. And so, no.
Okay.
That's a question I think we could maybe explore in the next grade evidence review.
There's a question about bicarbonate, and I want you to share with us uh,
Yeah. Let me see what
that.
the question is.
What's about bicarbonate during resuscitation?
Okay, so it's not in any, it used to be again in all of the algorithms, it's not there. We have not addressed it in the Pearls manuscript. I think if there was going to be a diagnosis in which it would be particularly helpful, it would be hyperkalemia. Um, we all have heard, and I know we've seen in our own eyes, that if you give bicarbonate, you will see your vasopressors work more effectively. That is just an observation that many of us have had. Um, I don't think it is wrong to give bicarb in a cardiac arrest. That's not contained in Pearls. That's my own personal opinion. The idea here that, particularly if you have a ventilated patient, the idea that it's going to cause some kind of intracellular ischemia, sure. I mean, I just don't know what that would look like. Someone is arresting, they are ischemic. The idea that this drug, which is going to buffer an acid, is going to make that ischemia worse, I'm not sure I personally believe that. That's another one for grade to evaluate.
Yeah, it is quite controversial, especially since we have a witness cardiac arrest, one that has a cause, and maybe we
Yeah.
should make more focus on the solving the problem or the sublying cause,
Yeah.
and not uh, making the use
Yeah.
of any other drugs. There's another patient, then another question. What patient characteristics or arrest scenario would make you advocate for ECPR in the operating room? And do you believe
Hmm.
Pearl should formally incorporate ECMO activation pathway in future editions?
We have ECMO actually now listed in the algorithms, both in the comprehensive algorithm, the left ventricular shock and the left ventricular shock and right ventricular shock algorithms. I think, ECPR, let me give you the ideal scenario and the not ideal scenario. So the ideal scenario is a heart that is failing and you have an arrest from a failing heart. I think there's much more value in that scenario than in a patient who is hemorrhaging. Hemorrhage with ECPR just does not solve the problem.
Okay. There's a question, maybe you can share your thoughts about it. It's about Bessel-Jarisch syndrome in the operating room and how it frequently is associated with cardiac arrest.
Yeah, I think spinal arrests are a wonderful example of the Bezold-Jarisch reflex. Very likely, you have this massive reduction in venous return that activates stretch receptors in the atrium, which then sends a signal to the brain, which then sends another signal back to the ventricle, I think, and says, "Hey, let's slow it down." So, yes, I think what's interesting is to remember that the Bezold-Jarisch, which is basically a hypervagal scenario, responds to volume. The heart rate will go up when you give volume, unlike other circumstances in medicine.
Yeah. I have, well, I told you that I had this idea that I wanted to end the questions. Since there is no other one, I'm going to share this idea. And it's when you have a cardiac arrest and you're giving CPR, you know which rhythm, or you probably know which rhythm you're treating, right? Like ventricular fibrillation or ASAP or any of them. But part of Pearls has been starting CPR with any other tools, but checking the pulse, right? Using HCO2 and so on. If I start giving CPR when we are at 20 or 15, and it is indicated, I mean, there's no other any other cause, which type of this standard classification of cardiac arrest rhythm or group are we treating? Is it ASAP or which rhythm would you put it? I've been thinking that could be pseudo uh, ASAP, but not sure and wanted to ask you.
Yeah, so the CPR and end tidal CO2 is really interesting because it is, I think, in some ways acknowledging that we can do chest compressions before we lose a pulse. So severe hypotension. Like, do we really need to wait for the pulse to be lost? I mean, like, why? Like, what's so magical about that? And so from a rhythm or degeneration into a rhythm perspective, I think that's going to put you in the non-shockable rhythm area far more. Because if you go into VFib, I think you're just going to have an end-tidal CO2 of like 5 to 10. Like it's going to just go down extremely rapidly. There's going to be no moment of intervention before that VFib, probably with end-tidal, unless you're sort of having a PEA type scenario that degenerates to VFib. So I'm not sure if I'm answering your question right, but I think it's going to be mostly PEA.
Maybe pseudo PEA?
Several PEA?
No, pseudo. Like pseudo, the one that we use
Oh,
in
pseudo PEA. Yeah.
pseudo. Yeah, that could be.
Yep, for sure. You could see it because the cardiac output in pseudo PA is not that great. Yeah.
Yeah, that was like this doubt that I had, and I think we could classify it in pseudo. Well,
Pseudo?
yeah, and it could make it easy for which rhythm are you treating,
Mm,
and oh, we are treating this pseudo. That we're
right.
preventing cardiac arrest. So to close or to make this idea stronger, because we have had a lot of discussions about this topic. Um, Giving chest compressions could be a tool for cardiac arrest prevention, and it is okay to do it. I'm trying to make a string of this idea because when we as anesthesiologists do that and we take the patient to big care for another, I mean, maybe for the ICU, they argue with us that
Yeah.
uh, why did you give it
Yeah.
CPR if it not was in cardiac arrest? So, what's your thought on
So I
that?
would say it was enough of us for us to think it was a cardiac arrest. But let me give you the opposite example that should make us feel really good about what we do. I remember I was walking in the coronary care unit, and this patient had an arterial line. The arrest team could not feel a pulse in this patient. Patient had an arterial line, and the blood pressure was 300. And they kept giving epi because they could not feel a pulse. And that is the point. Like, if you are so algorithmic that you do not think about what is happening in front of you, I don't think you're doing as good of a job with resuscitation as you possibly can. And now I think you can say, well, actually, there's the ASA has have the Pearls guidance suggests it end-tidal CO2. Although I have to say, I don't think we addressed end-tidal CO2 in this manuscript, but in the previous ones we did. Um, but I think that's another good question for next time is when to start chest compressions.
Okay. One more. Well, if you still have time, one
Yeah.
more questions. Okay.
Yes.
Um, um, well, it just got it off my mind. Um, yeah, pulse oximeter, pulse oximetry, the wave.
Mhm.
I know it's not validated. Sometimes it is not reliable, but could it be if we integrate every parameter a tool for guiding CPR, quality of CPR?
I don't know about quality of CPR. I think it would be very unreliable because you're not going to generate enough of a cardiac output. And I just feel like the movement of the patient will make that unreliable. We have end-tidal CO2, and I got to say that is amazing for quality of CPR. And if you can titrate to that, I think your patient has the best chance.
Okay, okay. There's a new question. It is a pretty long one, so I'm going to read it, or we can both do it. In the
Sure.
setting of emergency surgery for acute mesenteric ischemia requiring laparotomy, a patient develops severe hemodynamic instability associated with ongoing myocardial ischemia, accompanied by electrocardiographic changes despite optimization of oxygen delivery, correction of anemia, vasopressor, and other measurements. The patient suddenly deteriorates to severe bradycardia and ultimately cardiac arrest while surgery is still in progress. In this scenario, what would be the most appropriate management strategy? Especially, how should the team balance ongoing resuscitation, potential coronary reperfusion strategies, ECMO or mechanical circulatory support, and the need to complete or abbreviate the abdominal procedure?
Wow, this sounds like a board exam question. I like it. Um, I think the first step in this scenario is to do an echo. And I think once you see what the echo shows, it just changes the entire algorithm for where you're going to go. If you have a hypokinetic heart, then I think thinking about mechanical circulatory support certainly becomes a conversation. If you have a very vasodilated heart from the mesenteric ischemia, then I'm not sure you want to be going down the mechanical circulatory support route. So that's the first step.
Okay, it's having that phenotype, right? So you
Yeah,
have
yeah.
an idea which one of the problems is the biggest one.
But certainly ask for help. I mean, I think, getting a consult for this earlier rather than later is good. Um, yeah, this is a difficult situation, obviously.
It is, and I think one of the main messages that I am taking home from the lecture is to be very practical.
Yeah,
I mean, norepinephrine or epinephrine, just use one.
yeah.
Not that uh, simple, but the message is use one. Don't let it get worse.
I think the
Um,
question here is, would you complete the procedure? And I would say yes, because the patient would be dead. Or you say, look, we're not going to complete it and we're going to move to palliative care.
It is a complex decision, but
Yeah.
even if we close the patient, we have to decide if we are going to take the patient to cath lab, right?
Yeah.
I don't want to be taking care of
First
it.
would be mechanical support and then cath lab, I think, if you can do it.
Wow, mechanical support and open abdomen.
Yep.
Wow,
Yeah.
Ligia, you should tell us what happened to that patient. What
Yes.
was the decision that you made? Okay, okay. She said yes. Maybe she's writing. Any other questions? There are questions in YouTube actually.
Oh, wow.
Uh, uh, do AHA or ILCOR have plans to conduct randomized control trains for prone CPR?
Not that I know of, no. I mean, I think it would be very hard to enroll patients into that study, so I don't see that one happening.
Whoa. Well, there's a question, but I think it's not that specific, the answer, but I'm going to say it. Is air embolism considered a reason why cardiac arrest occur during posterior spinal surgery in prone position?
Yeah, it can be. I've definitely heard of or read cases of that happening. It can also happen with like irrigation of the fluid. If let's say someone has infected hardware in the back and they're cleaning it, and that air bubbling thing can get into an open vessel. So yes.
It could be. Well, I have another question. It is about when to stop CPR in the operating room in a witness and monitored cardiac arrest. For example, if we have a patient with LAST that we might have to do CPR for a long period of time, uh, and we do not want to stop. Uh, Using these physiological parameters for guiding CPR quality is a good reason to say we should keep going, or to say it is going to be okay, or it is probably going to be okay, the patient, if we keep going.
I think the question we have to ask first is this reversible? So LAST is a great example of a reversible cause. Once the toxin is gone, the heart should be working again as long as we've been perfusing the heart. That's a great example for an ECMO patient if you have the ability to do that. The if it is not reversible, then I think you need to think about ending it. The parameters we can use are end tidal CO2. The lower the end tidal CO2 after 20 minutes, the less likely you're going to get a return of spontaneous circulation. And echo, I think, can also help. And then just the overall scenario, like sometimes there's just catastrophic bleeding that cannot be controlled. In that scenario, you would need to call it.
Okay, okay. Ligia says that following resuscitation, they did VA ECMO. Uh, they decided to continue and complete the surgery. It remained on ECMO support, and then they went to cath lab. Ultimately
Sounds like what
died.
we were thinking about.
There's a question at the end. In your opinion, was this the most appropriate management? Well, strategy. Yeah, I think it was, right?
Yes. You won't be able to do cath lab if you're in such distress. Like there's just not, and what if the cath and what if the coronaries are not a problem? You've wasted all of this time not being on circulatory support with low perfusion and your organs going down.
Quite interesting case.
Yeah.
Okay. Any other questions from the auditorium, or let's see, YouTube? Mm, mm, no, I don't think there's more.
If there is people who is working with pediatric cardiac arrest in
I have been asked if you collaborate or known of groups that are working for a protocol in the intraoperative period in pediatrics.
Yes. We are trying to expand the Pearls world to include pediatrics, and the ASA is trying to find people to do that. So that process is underway, and I expect that the next iteration of this will include pediatric guidance, which I know nothing about.
Okay, okay. So it is a work in progress.
Yeah.
Okay. Mm, well, they're asking in case of suspected air embolism, is there any evidence supporting positioning the patient on lateral decubitus and try to aspire the bubble through a central line?
I think that's, is there evidence? Like I don't think there's going to be a randomized control trial. That's one of those things where it's just people have reported what they've done and it makes physiologic sense. We, at least where I work, do not place the type of central line where it'd be easy to aspirate a lot of air. So I haven't really heard of anyone ever doing that. I think putting the patient in a different position is not an unreasonable thing to do, but often you could do things before that that resolve the air embolism. Like I think about what are the cases that are like super common for an air embolism would be things like a laparoscopic hepatectomy where you keep the CVP and fluids really low and you have this abdominal pressure. I've probably had like three or four of those in my career. And you don't have to flip anyone. You just give fluids back and support them and say, can you stop the insufflation? And in the neurosurgery world, often you're like in head pins when you're in that head up position to start. So that would be very impractical to flip the person, but it's not wrong. But the evidence, I don't think, will ever be more than case reports.
Exactly. Um, I, I was thinking about a question and then I just forgot it. Um, uh, uh, well. Oh yeah, I know what was the question I wanted to ask. Um, about the if we have a an the possibility to make an immediate defibrillation. What's your opinion about the three stack defibrillation technique in the first minute?
I think if you're comfortable doing it and you think it's appropriate, it's fine. Pearls has not weighed in on that issue in particular. There has been um, a recommendation of sort of the double sequential defibrillation if the first round doesn't work. Um, so I don't think it's unreasonable. I would probably start with traditional defibrillation first in my practice, and then escalate if that doesn't work.
Okay. Okay, I don't think I have more doubts right now in my mind. But see if the audience they don't have any more. Let's see in YouTube. Uh, 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 uh. Mm, mm. They are asking if you're going to have a Pearls course with simulation in your hospital. Maybe you can tell them about the one that's going to be here in Mexico.
Yeah, so I'm going to be coming to Mexico in October to the ABC Hospital, which hosts a Pearl course almost every year. We don't have a formal course in our hospital. We sort of just do regular residency training teaching. So it's just integrated into their years of training. But we are contemplating next year doing an actual formal course in New York City. We'll see.
I'm pretty sure we will be there. A lot of the students here, or the audience here today will be there. Very gladly to meet that program. Well, if there's not any other question, oh, there is one. Again, Emiro from Colombia says, is there any evidence supporting the use of regional cerebral oxygen saturation monitoring during resuscitation? And is there a validated threshold or target for that value, for that technology to predict?
Not that I know of. And I think it would be hard to titrate to cerebral oximetry. I think it's not as reliable as things like an end-tidal CO2. Um, but I'm just not familiar with that literature if it exists. It's a good question for me to have some homework on after today to look up.
I have had some interest in that topic, and I have seen that there's a lot of correlation, even in pre-hospital settings, not only in hospital. But I don't think we have like the number or the precise number or trend that the regional saturation should have. But it is quite interesting the way
I think
that
it
they
could
are
be a
studying.
good marker of prognosis potentially, but I'm not sure like chest compression titration. I don't know.
Actually, I have given CPR for cardiac arrest patients with NIRS
Yeah.
bilateral, and it does guide you
Yeah.
well.
You'd push harder.
Not as an arterial line. Maybe with the arterial line, I just say not more harder. I mean, I have enough diastolic blood pressure, so it
Mm,
is enough, not much harder. But there's something else wrong, so you start looking for what's wrong if NIRS
mm,
does not go up.
sure.
So not maybe physiological CPR, but around physiological patient
Right.
during CPR, something like that.
That's a good one. I'll have to look that up. That's great. Thank you for sharing.
Well, yeah, no more questions, I think. So thank you very much for being with us this late. It has been amazing. You're incredible. You share all your knowledge. So thank you. Uh,
Thank you. I appreciate it. I'm very grateful to be a part of your community.
and I don't know if you have one last message that you want to give to the audience, so we can call it tonight.
I'll just say again, thank you. I'm grateful. It's great to have a community that comes together that wants to learn together. And I feel very privileged to be a part of that. So thank you.
Thank you.
All right.
Eh,
Good night.
and
Buenas noches.
buenas noches.
Okay.
Daremos solo algunos avisos finales, ya lo haré en español. Dr. Moitro, if you want to get out, it's okay. I'm just going to give some advices or some notice from next webinars.
Sounds good. Thank you.
Em, el próximo webinar en 15 días todavía no tenemos confirmado ponente, pero lo que sí tenemos confirmado es que el doctor Moitra estará con nosotros en Comexane en varios módulos. Estará tanto en el nuestro personal de Racel como en el de paro cardíaco intraoperatorio, y creo que por ahí tendrá una charla magistral, entonces no se la pierdan. También ya les comento del curso que habrá en ABC, que es un PEARLS como tal, pero aquí en la Ciudad de México. Y bueno, pues esa sería toda la actividad de esta noche. Muchísimas gracias, como suelo comentarles. em, pues esto no lo podríamos hacer sin que ustedes se conecten y estén presentes. En general, les puedo decir que los ponentes internacionales han aceptado las invitaciones cuando se enteran la cantidad de asistentes que tenemos y todos los países que representamos. Entonces, yo les agradezco pues que estén aquí, que nos apoyen. De esa manera seguiremos buscando más ponentes. Y bueno, pues como siempre les digo, sin ustedes esto no podría ser posible. Siempre estamos aprendiendo. Hoy yo me llevo grandes ideas a aplicar, a ajustar en nuestros programas, a mejorar aquello que no estaba del todo bien y a implementar aquello que no habíamos implementado. Y bueno, pues espérenlo en las publicaciones, en los cursos, en los talleres, en todo, ¿no? Siempre el objetivo, recuerden, es lo que no estaba bien, mejorarlo y lo que faltaba, pues agregarlo. ¿De acuerdo? Entonces, muchísimas gracias, que tengan ustedes una bonita noche y todavía ponente de la próxima sesión no tengo confirmado, tal vez un ponente internacional, pero bueno, en cuanto ya tenga la confirmación, yo les haré saber. El video ya está en YouTube, es un live, entonces en cuanto termine yo de transmitirlo, ustedes van a poder, poderlo ver y compartirlo. Así que muchas gracias y que tengan ustedes una bonita noche.